tardes. Gracias por estar aquí. Voy a hablar en español. Mi nombre es Paula Díaz, vengo desde Medellín. Estoy feliz de recibir esta invitación, de estar con ustedes. Gracias, Rita, por esta importantísima oportunidad de presentar AMNET a toda la comunidad brasilera. Es para mí un honor enorme presentar a nuestro gran maestro, colega fundador de AMNET, el doctor profesor Bernard Choi, quien será nuestro conferencista de la tarde, nuestro primer conferencista. Me permito contarles una breve biografía del doctor Choi. El profesor Bernard Choi es investigador principal de la Agencia de Salud de Canadá. Tiene una maestría en seguridad y salud ocupacional realizada en el Reino Unido, un doctorado en epidemiología de la Universidad de Toronto y antes de unirse al gobierno de Canadá, donde trabajó por mucho tiempo. Luego fue profesor de la Universidad de Toronto, de la Universidad de Ottawa, de la Universidad Shantou en China y es autor de una cantidad innumerable de artículos, particularmente en áreas de la salud ocupacional y la salud ambiental, la epidemiología, la vigilancia de las enfermedades crónicas, los factores de riesgo, la traducción de conocimientos, investigación en políticas, evaluación de programas y salud internacional. El profesor Choi ha desarrollado una serie de procedimientos estadísticos para la salud pública y es miembro fundador y miembro honorario por siempre, forever professor, de la Red de Vigilancia de Enfermedades Crónicas de las Américas, AMNET. Damos una cordial bienvenida, profesor. Adelante. You are most than welcome, Professor Choi, please.
I prefer this one. And this one. Okay, that's me, the name, Bernard Choi. I'm a professor in the Division of Clinical Public Health that I mentioned this morning. Clinical and public health never come together, but for the first time, we are trying to make them come together at the University of Toronto in Canada. That's my email address, bernard.choi@utoronto, one word, universityof-toronto.ca. Currently, my email address in the MNet website is invalid. It is not wrong. But if you send me email to that address, I can never receive it because that's my government job. And now I'm no longer with the government. So, and I'm going to talk about one of a paper. Right? I know how to change. For those of you who are sitting at the back and cannot see me, this is me. This paper has got 18 authors, 18 professors at the University of Toronto, talking a study of ourselves. It was a study on the professors by the professors. And it has to go through ethics review. We are the authors as well as the participants. I will tell you why. If we look at the PhD, MD, about half of us are medical doctors, half of us are public health doctors. And that's the idea. Has anyone seen this painting before? (1562) oil painting by Pieter Bruegel the Elder. And this painting talks about the Black Death, 1347 to 1351. This is the kind of situation that public health and clinical health doctors are facing since thousands of years ago. There are lots of pandemics coming and going. Don't forget that obesity is also a pandemic. We are not just talking about COVID or any infectious disease. The effect of, or even health inequity is a pandemic. It is something that's not really shown in real life, but it is occurring in the background. How severe is a pandemic? Look at this person here. They were having fun, just like our lunch. Yeah, a banquet. When COVID came, the hardest hit areas were the cruise ships. They were they were in an enclosed space, and they all suffer. See, this is the banquet, and a pandemic can hit the kings and queens and the noble people as well. The dead bodies are attacking the king. The most cruel scene is this one. I want to enlarge that view. You can see dead horses and dead people attacking uh, live people. And this is the time of a medical global epidemic, pandemic situation arising. Under that situation, how would we respond? You see, people are trying to fight back, and of course, led by medical doctors, led by public health doctors. So we all work together during an emergency of this scale together. Now, if we look at the history, at the very beginning of time, there was only one thing, which is clinical medicine. The god of medicine, Asclepius, is shown here, and he represents all the medical doctors. A few thousand years ago, the medical doctors have to do everything, including curing people, treating sickness, and things like that. And they have also to make sure that the environment is clean and there's hygiene. So prevention as well. The doctors have to do everything. Only one type of doctor, they do everything. Later on, the clinical medicine divided into clinical medicine, those working in clinics and hospitals, and public health. So the question is, when we are facing a very severe public health on a population-based problem, should we have the two groups working back together or not? Of course, the answer is yes, but it is not that easy to bring clinicians and public health people to come to work together. There are lots of barriers, culture or social norms, and we have overcome those. And so the this paper, we wanted to find out the promoters and barriers, and especially why we want to do that and what is clinical public health. That's why our university created the first department of clinical public health in the world. This is our history. We 1843 at the university, we had our faculty of medicine. I do not know your history of the school. I think maybe your faculty of medicine is older than ours. I'm not- No, you only have 50 years. Here, oh, 250. So the average is about the same with Canada. So 84 years later, we decided that everything done by the Faculty of Medicine is not so good. The, the public health people wanted to get out and become independent so that they get more money for the project. They do not have to rely on the fee of medicine to approve their project. So we got the two different faculties together, separate. But then after 48 years, we decided that there is a close relationship between clinical medicine and public health. So they came back together. A faculty of public health becomes a small department within the faculty of medicine. And it became public health sciences department still within faculty of medicine. But then later on, we decided that again, public health should have its separate status. And so the School of Public Health was created. And after that, we feel that the public health people should work with clinical medicine again. So in 2012, we created the first ever in the world clinical public health division. So the story here is that this is like two pockets. Those small animals with spines. In the winter, the two friendly porcupines feel cold, so they fight together to keep warm. Yes, but then when they get too close, the spines will be killing each other. Is not comfortable, and they try to separate and come together and separate and come together. That's the whole history. The term clinical public health from our literature research appeared in a Japanese journal without any definition in 1972 and in a British journal in 1974, again with no definition. 2012, we used the term clinical public health to describe our division. And 2 years later, there was a clinical public health program in the States, George Washington University, and then the same year in the University of South Carolina. The objective of this exercise of a group of professors studying themselves for a publication is to define and understand the meaning of clinical public health. We ask our faculties, what are your definitions? And we also want to conceptualize a working model so that we know what kind of things we need to prepare ourselves. The methods. It was a two-way anonymous online opinion survey done in 2016 and 2017. We have a feedback of wave 1 results to the wave 2 participants, so they know exactly what the wave 1 results were. The investigation team members were also participants of the surveys, and we need a research board ethics approval. Wave 1, we asked about the demography. What kind of doctor are you? Are you clinicians? Are you whatever? What is your definition of the term clinical public health? What are the advantages, disadvantages, strengths, and weaknesses of clinical public health? So we analyze the first wave data and put it back to the wave two. Wave two, we ask the participants to rank. In the wave one, we received 33 definitions. We asked in the wave two, their ranking of the proposed definitions. What are the pros and cons? And do they like the term clinical public health? Suggested collaborative projects. At the time, we had 187 professors in the division. We had a response rate of 25%. A 25% among the professors is a very good response rate, believe it or not. In our surveys, we want an 80% response rate. But in a survey of ourselves, the professors, they're so lazy that they are not going to participate. But that's a good response rate for the purpose of this study. A lot of them have a master's degree, MD, PhD. There were a lot of different fields of training, from bioethics to urban health, psychology, even arts, computer sciences. We have a good mix of different disciplines. Many of them, 40%, work in the university or a research institute. Clinical practice, 14% in the government or in the local public health departments, or 20%. The wave two response rate was about the same, 22% here versus 25% in the first round. Now, this is the most interesting thing. We received 33 definitions, and we put the 33 definitions into 6 categories. So the first category is that clinical public health is the intersection of clinical practice and public health. Clinical practice, public health, this is the intersection, and this is clinical public health. Number 2, it is the intersection of primary care, preventive medicine, and public health. More or less the same idea, but in medicine, they have got 2 groups here. This is very different because clinical public health is itself a discipline which is interacting with a lot of other sectors: biochemistry, microbiology, computer sciences, fine art, and so on. Number 4, clinical public health is within public health. Number 5, clinical public health is within clinical medicine. This is the most interesting. Clinical public health does not exist because they cannot mix, they cannot come together. So my question, this was an anonymous survey. I do not know who answered what, but I would like to ask these people, then why are you in our department? Our department is the collaboration of clinical medicine and public health. You are here and you are saying that there's nothing in common. So interesting. And then we also ask for strengths, weaknesses, and so on. Strengths, like this can encourage, clinical public health can encourage interdisciplinary collaboration. It is a new field, promotes forward thinking, but there are weaknesses, confusion, because it is not clear what really it means. Too narrow in scope, too clinical, not inclusive enough. And there are opportunities for collaboration, like addressing non-public health issues. This may be the group of multidisciplinary experts who can work together to find solutions to new problems. If we are still keeping within clinical medicine and within public health, we may not be able to go outside, to think outside the box. It can provide new approaches and raise the profile. And there are threats like excluding potential collaborators. If I'm not in clinical, can I join clinical public health? Of course, the answer is yes. But since you say this is clinical public health, people who are not working in clinical may feel excluded. Suggested collaborative projects. I'm going to skip this. I'll let one picture be taken, and then I'll skip this because I would like to have some time for questions. But basically, a lot of projects can be done. Number 6, new thinking outside the box. Think of a health issue, and there is a collaborative project, and that's very true. Discussion. Clinical public health could be useful for the collaboration of clinicians and public health professionals on complex population health issues. The simple ones, we do not need collaboration. Like if you have a cough, a clinician can deal with this. But if we have got things that's more complex, we need a collaboration. So after we published this paper, there were a lot of letters to the editors. Of course, when you have a paper published, and if you see that people are responding, sending letters to the editor, it means that it is a good paper and people are trying to respond to it. This is a letter from Professor Ramsey. You see the green means, yes, they agree with our proposal. The current COVID-19 epidemic has taught us that creating successful public health policy is an extremely difficult task, requiring a high multidisciplinary approach. And of course, there are also other people who said no. Professor Young said, can public health be clinical? No. Dictionary defines clinical as fascinating and pertaining to the bedside of a sick person. Public health is primarily devoted to promoting health and preventing disease in the population. One is in the population, the other one is a single person, so they cannot mix. My thought, clinical public health is not one joint discipline to replace clinical medicine and public health. It is a third option. This is a health crisis. It is like fighting a war. This is a health crisis. Clinicians are fighting against the health crisis from their perspective, using their traditional kind of knowledge. Public health is doing the same thing from a different angle, but it would be helpful if we have a third joint forces from the clinicians and public health coming together to help. So this is the third option. Conclusion. We have identified 6 definitions, with the intersection of clinical practice and public health being the most popular among the respondents. The lack of a full consensus is itself interesting. This is a group of very highly intelligent professors, and they cannot agree on the definition. Some are saying that the 2 groups cannot come together. Our study is a starting point for putting different perspectives on the table and identifying new opportunities to deal with new pandemics. And it is time for the 2 groups to join forces, and hopefully we will continue the work and come up with solutions so that we are stronger in response to public health emergencies. I think this is, yeah, thank you. Thank you very much.
Professor, have you, was it possible to hear when I was without the microphone?
I don't know.
Did you hear what I was saying before the microphone?
I was busy distributing the microphone.
Oh, I'm sorry. Okay, so maybe
Sorry,
I'll
could you please repeat that?
I'll resume.
Now we've got 3 microphones.
I just thought that maybe to bring a Brazilian perspective of how we are dealing with these differences. I'm sure we have also differences in clinicals and public health, but I am a family doctor, and here in Brazil, we the name actually is family and community medicine. So I think maybe this section of clinicians have, and also our primary healthcare here is organized in a way that people, we see the community, we see the territory. People, they access a primary health clinic that is within the territory. So healthcare units and family and community doctors, they think also about public health, and this intersection is kind of natural in this scenario. So, but very interesting, your presentation.
Thank you.
Thank you, Professor Bernard. This was the last question, but we have the choice to see your paper published, maybe? Okay. The paper is published. We can share with you. Thank you very much, Professor Choice.